Hello, good evening. This evening we will be talking on secondary fungal infections during the COVID pandemic. It is exactly a century ago when we had the 1918 influenza pandemic, and on where almost more than one third of the world's population was affected by the pandemic. And it was found on examinations of the pathological material that the cause of death in these patients was not due to the influenza virus itself, but it was due to secondary infections. Similarly, after 100 years, we are facing this pandemic of COVID-19, where again, lot of secondary fungal infections are being seen in these patients, and these fungal infections are seen in predominantly critically ill COVID-19 patients and are the cause of death in a significant number of patients of them. So what we are going to see today is what type of fungus are there we are seeing in these patients, how to diagnose it, and how to treat it effectively to prevent the mortality. What makes these people more vulnerable to fungal infections? Although the super infections were rarely reported at the beginning of the current pandemic caused by the SARS-CoV-2, but now, after so many months of the COVID pandemic in place, there is a rise, particularly about secondary fungal infections. And this COVID-19 virus invasion, what happens is once the invasion by the virus occurs, it results in the release of certain parameters called danger-associated molecular patterns, or DAMPs. These DAMPs act as endogenous signals that exacerbate or increase both the immune and the inflammatory response, leading to injury of the lung, and they play a central role in the pathogenesis of fungal infections. These patients also inherently have a reduction in their CD4 and CD8 counts, and that itself makes them more prone to develop these fungal infections. Also, it is found that the collateral effects of host recognition pathways, which are required for the activation of antiviral immunity to fight against the coronavirus, these itself may contribute to a highly permissive inflammatory environment favoring fungal pathogenesis. This paper, published in the year 2020, talks about the risks and features of secondary infections in severe and critically ill COVID-19 patients. It was found that this was published from China, and showed that almost 58% of patients of COVID-19 who were on mechanical ventilation and critically ill in the ICU, they developed secondary infections, the common of them being respiratory, bloodstream, and urinary tract infections. Now, among the respiratory infections, it was the fungi which constituted almost 8% of these secondary infections. And the risk for these secondary infections definitely increased after receiving mechanical ventilation and many of the intravascular devices. The prevalence and risk factors of fungal infections are studied from various centers. In the United Kingdom, it was found that 26% incidence of invasive fungal disease versus 12.6% incidence of invasive yeast infections. Chinese study again showed that in 58% of COVID-19 patients, about 8% developed invasive fungal disease. And it was again the SARS-CoV-2 associated pulmonary aspergillosis, what we can call as CAPA. COVID-associated pulmonary aspergillosis has been found with the predominant fungal disease in this population, followed by Candida and other infections. But with particular reference to Indian epidemiology, Indian patients also reveal, in addition to CAPA, we reveal a significant burden of invasive mucormycosis. And this is seen not only in severe COVID patients, but even in mild to moderate SARS-CoV patients in India. Why this is so? This is predominantly because we have a hot and humid conditions in our part of the world favoring the growth of the mucormycosis. And one common factor which was detected was uncontrolled diabetes or hyperglycemia, which makes these patients vulnerable to develop mucormycosis, invasive mucormycosis infections. The predisposing factors for these fungal infections, which are very commonly seen in the ICU, patients are requiring a lot of catheters, indwelling central venous catheters, parenteral nutrition with a background of diabetes, renal failures, and they receive multiple antibiotics. And the more the length of the stay in the ICU, the more is the risk of developing the invasive fungal infections. Then this review was published from Taiwan, where they studied about the pulmonary aspergillosis associated with COVID pandemic. It was found that Aspergillus species caused co-infections in patients with COVID-19, especially those who were severe or critically ill. The incidence of invasive pulmonary aspergillosis in these COVID-19 patients range from anywhere from 20% to 33%. And this the variation in this incidence probably because of the difficulty in coming to a firm diagnosis of aspergillosis because of the nature of the diagnostic material required to make a firm diagnosis from these critically ill patients. ARDS requiring mechanical ventilation was the commonest complication seen in these patients, and overall mortality was very high, even up to 65 to 68%. Among the Aspergillus species, it was Aspergillus fumigatus, which was the most commonly isolated species, causing co-infection in COVID-19 patients. Regarding the treatment, we know that voriconazole is a treatment of choice for these aspergillosis, but in these COVID-19 patients, we have to be cautious about giving voriconazole. Voriconazole has a lot of drug-drug interactions, so a therapeutic drug monitoring of voriconazole is mandatory, and this can also enhance the cardiovascular toxicity of some of the anti-SARS-CoV agents which we use in these patients. So then what are the challenges in the diagnosis and management? Symptoms of the fungal disease can mimic that of the COVID-19, like fever, cough, and shortness of breath. Therefore, very difficult to make out clinically whether it's a fungal infection alone or a combination of both or only one. Therefore, laboratory testing is very important to determine if a person has a fungal infection in association with COVID-19 or not. But it is to diagnose this pulmonary aspergillosis is a real big challenge. So this fungus stays harmlessly in the airways. It inhabits the airways harmlessly. But whenever the pulmonary immunity is impaired, this aspergillus spores starts to grow and invade and cause inflammation and spread into the lungs. So the diagnostic markers, we see basically the confirmatory diagnosis in invasive pulmonary aspergillosis is of course a lung biopsy and sending it for histopathology and cultures. But this is not possible in most of these sick patients. So every patient, we cannot go for a lung biopsy for fear, or even doing a bronchoscopy in these patients is quite risky. So because we have the fear of spreading the coronavirus itself. So though the bronchoscopy and the BAL are important in this, but most of the time we have to use a non-directional bronchoscopy or what we call as the mini BAL, and also a tracheal aspiration, and send the material for biomarkers of fungal infection like galactomannan, beta-D glucan, etc. And also the same fluid can be sent for fungal cultures and drug sensitivity. So that is the best we can do in these patients, and then come to make a diagnosis. And as we have already told, there is a lot of drug-drug interactions between the azoles, that is the voriconazole and other drugs. Therefore, therapeutic drug monitoring may be required in most of these cases. So COVID-19 pulmonary aspergillosis, kappa, in other words, usually occurs in patients of COVID-19 who are on ventilators and are critically ill, and their symptoms are very non-specific, exactly mimicking that of the COVID-19, and they are very serious infections which can cause illness and death. Therefore, all the clinicians who are treating with these critically ill patients in the ICUs, especially, we have to keep our eyes and ears open and always look for the possibility of aspergillosis in those severe COVID-19 patients who are worsening in their condition, worsening sepsis, worsening respiratory function in spite of the various antibiotics receiving and other treatment being continued. Even though they may not have the classical risk factors for invasive aspergillosis, but still this has to be kept in mind in view of the existing circumstances in these COVID-19 patients. And as we told already, testing for kappa usually involves material to be taken from deep into the lungs, like a lung biopsy or a bronchoalveolar lavage. Therefore, we have to, since it is difficult to do this test in each patient, we have to depend sometimes on the serum or the bronchoalveolar lavage or tracheal aspirate, galactomannan, and the beta-D-glucan, and also, if possible, fungal culture. A word about Candida Oris. Candida Oris is now actually called a superbug. It's an emerging fungus which is causing outbreaks of severe infections in many of the United States healthcare facilities. A study from India has also shown that Dr. Chaudhary, I think from Delhi University, has isolated about 45 patients with the Candida auris. This virus is found in sandy beaches of Andaman and Nicobar, and this is found to be now affecting the COVID-19 patients as well. Probably this is due to the changing infection control practices during the COVID-19 pandemic, including the limited availability of gloves and gowns. So there is always, we must be aware to look for these infections as well in COVID-19 patients. Then there are other fungus infections like apart from Aspergillus and Candida, and we have to keep in mind Coccidioidomycosis, histoplasmosis, blastomycosis, which exactly can present like a COVID infection. So these, though they are quite rare, but these fungal pneumonias are occurring in these patients, and these have to be kept in mind when planning the treatment. Coming to the Indian scenario, a wonderful paper was published where they published about post-COVID-19 mucormycosis recently, and from the frying pan into the fire. And this showed that India had the dubious distinction of being the capital of both diabetes and mucormycosis. And we all are aware of the unholy association between diabetes and severity of COVID-19 patients. Mucormycosis actually is seen more commonly in uncontrolled diabetic patients, and forms one of the most devastating complications of this group of COVID-19 patients, with a high mortality ranging from 40 to 80%. And India contributes almost 40% to the global burden of this mucormycosis. And probably, as I told you earlier, our hot and humid climate in tropical countries probably make it more common for this fungus to be present in the Indian subcontinent. And of course, the uncontrolled blood sugar and hyperglycemia is another added risk factor in these patients to get infection with this invasive mucormycosis. This paper was published in one of the recent journals. It talks about the COVID-19 infection, its treatment, the resultant immunosuppression, and pre-existing comorbidities, which have made the patients vulnerable to secondary infections, including mucormycosis. And the patients were treated with the intravenous liposomal amphotericin B, and few of them had rhino-orbital mucormycosis, and all of them were found to have uncontrolled type 2 diabetes mellitus. Uncontrolled diabetes and the use of corticosteroids actually make the patients increase their risk of developing invasive fungal infections and mucormycosis. And we all know that corticosteroids are required in most of these COVID-19 patients who are critically ill, and they increase the risk of getting these infections. So we have to be cautious and look for these infections if the patient is not improving and worsening with the routine treatment. An interesting case of rhino-orbital mucormycosis was presented again due to the extensive use of steroids, monoclonal antibodies like tocilizumab, and broad-spectrum antibiotics, which led to the development of this mucormycosis in a diabetic who was a 60-year-old long-standing diabetic. There's another interesting case which was shown of pulmonary mucormycosis, published in November 2020. It was found that SARS-CoV-2, which produces significant amount of lymphopenia, by itself increases the risk of developing opportunistic infections. So the more the lymphopenia, the more is the warning that this patient may be a candidate for developing opportunistic infections. So this case again highlights that the coronavirus type 2 might impair the immune response, irrespective of other conditions. The virus itself may impair the immune response, making these patients vulnerable to develop opportunistic fungal infections, leading to worse outcomes. So then with this background, let us see now what are the current treatment modalities for this antifungal strategies. We have 4 strategies to work on. One is a prophylactic antifungal therapy, second is empirical approach, third is preemptive approach, and fourth is of course the target therapy. Let us see each one of them. What is prophylactic antifungal therapy? Prophylactic drugs are given when there is no attributable signs and symptoms. Say, for example, if your patient is in the ICU and critically ill on a ventilator, and this patient has background involving catheters and he's on parenteral nutrition, so he's a ready-made candidate for fungal infection. So instead of waiting for him to develop fungal infection, you can give a prophylactic. That is where this category comes. Second is the empirical. Empirical antifungal therapy is given where there are clinical signs and symptoms of infection are seen, but no pathogen is identified. Third is the preemptive category, where the laboratory tests or radiographic signs are conclusive to invasive fungal infections, but no definite proof of histopathology or culture exists. It is predominantly the empirical and the preemptive types of patients whom we have to take a decision based on clinical suspicion, radiological findings, and then the presence of certain biomarkers like galactomannan and beta D glucan, and then start the antifungal therapy rather than waiting for the full biopsy to be taken, which is not possible in most of these critically ill patients. The targeted is definite where there's a definite evidence by histopathology or culture of the fungal pathogen and invasiveness of the disease. But this is very, very rare to get a firm diagnosis in these patients. So it is predominantly the empirical and the preemptive where we have to plan our antifungal therapy. Coming to aspergillosis, in invasive pulmonary aspergillosis, the guidelines say that voriconazole is a treatment of choice, 6 milligrams per kilogram body weight IV every 12 hourly on the first day, followed by 4 milligrams per kg body weight IV 12th hourly thereon. And then you can change to oral tablets and the dose of 200 to 300 milligrams as per the body weight. The alternative therapy where voriconazole cannot be given or where there are a lot of drug interactions can be liposomal amphotericin B in the form of 3 to 5 milligram per kilogram body weight, or a new drug which is coming very fastly is isavuconazole, which is given in 200 milligrams 8 hourly for 6 doses and then 200 milligrams per day. That is but still, the practically speaking, most of the patients are receiving voriconazole. If this is not possible, then primary liposomal amphotericin B. As I was telling you, predominantly we have to plan for empiric and preemptive antifungal therapy. If you have a doubt, you can start on voriconazole and then monitor the therapeutic drug functions. Liposomal amphotericin B, the problem is that you have to constantly monitor the renal parameters. So, okay, so but the predominantly voriconazole, as I told, is being used. The prophylaxis against invasive aspergillosis, some centers in Belgium have tried giving nebulized liposomal amphotericin B in this high-risk infections of COVID-19, high-risk patients who are in the ICUs and mechanically ventilated. Prophylactic liposomal amphotericin B has been given in a nebulized form. Otherwise, posaconazole is available in oral suspensions as well as in tablet form. The bioavailability of a tablet form has been found to be better than the oral suspension, the dose being 300 milligrams twice daily on day one, then 300 milligrams daily. But then the primary treatment still remains voriconazole. Coming to candidiasis, both in non-neutropenic and neutropenic patients, again, the diagnosis of invasive candidiasis has to be made basically on clinical assessment, risk factors, surrogate markers like beta D glucan or galactomannan, and culture, if possible, from non-sterile sites like blood culture or probably the bronchial wash if it is available or if it is possible to do in that patient. And once you make a suspicion of candidiasis, the treatment should be started as soon as possible. Treatment of choice is echinocandins, that is caspofungin, with a loading dose of 70 milligrams, then followed by 50 milligrams daily. It is given for 2 weeks after the culture becomes negative. Till that time, you have to continue this drug. In the other drugs are micafungin or enidulafungin is also available, where you give 200 milligrams of loading dose followed by 100 milligrams daily. Acceptable alternative for echinocandins can be fluconazole in the dose of 12 milligram per kilogram body weight, usually 800 milligrams as loading dose, then 400 milligrams on a daily basis, that is 6 milligram per kilogram body weight. This is given to those patients who had no recent azole exposure and which are not colonized with azole resistant Candida species. Again, the lipid formulation of amphotericin B is an alternative if these are not possible to be given. But the drug of choice again is echinocandins or caspofungin. In prophylaxis of Candida, again, fluconazole in the dose of 800 milligrams as loading dose, followed by 400 milligrams daily, can be used. It has been used in high-risk patients in adult ICUs with a high rate of more than 5% of invasive candidiasis. And it is also found that daily bathing of ICU patients with chlorhexidine has been shown to decrease the incidence of bloodstream infections, including candidemia, and this should be considered. Coming to zygomycosis and mucormycosis, a lovely paper is published in the global guidelines for the diagnosis and management of mucormycosis, and they formed one world, one guideline, which was an initiative of the European Confederation of Medical Mycology, and they found that the first line treatment is with high dose liposomal amphotericin B. This is strongly recommended. If you are not able to give liposomal amphotericin B, then you can give, second choice is intravenous isoconazole or intravenous delayed release posaconazole tablets. But again, the drug of choice is high dose liposomal amphotericin B. 3 to 5 mg is per kg body weight is a normal dose, but you can increase to up to 10 milligrams depending on the renal functions of the patient. But it is very difficult and expensive drug. So in countries like India, amphotericin B deoxycholate may be the only option available to us in countries like India because of the cost factors. So we have to monitor the renal functions when our patients are on amphotericin B deoxycholate. So if you summarize the fungal management of invasive candidiasis, if the patient is admitted, the scenario is a COVID-19 patient admitted to the ICU who is having all the risk factors like parenteral nutrition, is receiving broad spectrum antibiotics, not responding to your treatment. If possible, you do a mini ball or a tracheal aspiration, do a direct microscopy. If you find typical pseudo hyphae, then you send the biomarkers like galactomannan and Maldidorf. Maldidorf technology is a new thing which is coming, but still we in India, available with us is galactomannan. So we have to go on this test. If the galactomannan is positive, if your wash is showing pseudo hyphae, then start him on echinocandins, even in the absence of these investigations. If clinically you suspect that this could be Candida, then you can start them on echinocandins. Similarly, imagine your patient is a COVID-19, critically ill in the ICUs or mechanical ventilator. He is a diabetic or he is having glucocorticoid use with background of COPD, which most of the patients have here. And so if possible, clinically, if possible, you take the tracheal aspirate or a non-directed bronchial lavage or mini ball, send it for look for a proper direct microscopy, staining with PAS and GMS. If you find typical acute angle branching septate hyphae, which is the classical picture of aspergillosis, acute angle branching septate hyphae. And also, if possible, do a galactomannan test in the serum and also in the bowel fluid. Once this confirms, once this is positive, or even if there is a high index of suspicion, you can start them on voriconazole. The invasive mucormycosis is a highly, the mortality is so high. So if you are doubting these patients of COVID-19 in the ICU who is a diabetics, uncontrolled on glucocorticoids or other monoclonal antibodies, if possible, do a ball, look for non-septate or paraseptate ribbon-like hyphae. If they are seen, then the treatment of choice here, again, as I told, is first line is amphotericin B, liposomal amphotericin B and posaconazole. If it is not possible to give liposomal amphotericin B, then liposomal, amphotericin B deoxycholate can be given. But surgical debridement is always a requirement if it is possible in these patients. So the recommended treatment for the commonest fungus seen, that is COVID-associated pulmonary aspergillosis, as per the 2020 European Excellence Center for Medical Mycology and ISHAM consensus criteria. If your patient is suspected to have kappa, then and if he is found to be azole sensitive, okay, then you can start on voriconazole, that is 6 milligram per kilogram body weight, 12th hourly on day 1, followed by 4 milligram per kilogram body weight twice daily from day 2 onwards. The optimal duration of voriconazole is not known, but probably it is 6 to 12 weeks should be enough. But if the patient is immunocompromised for some reason, then he should be receiving longer treatment, might be necessary longer than 12 weeks as well. It is always important to monitor therapeutic drug monitoring with voriconazole, and the plasma trough value has to be kept between 2 to 6 milligrams per liter. In those patients, the other drug available where you cannot give voriconazole is isovaconazole, which is not yet available here, but the drug is available outside India, and it can be given in the dose of 200 milligrams thrice daily on days 1 and 2, followed by 200 milligrams once daily from day 3 onwards. In patients who are having azole resistance or likely to have azole resistance, it is again the salvage therapy has been found to be amphotericin B in the dose of 3 milligram per kilogram body weight, but then you have to monitor the renal parameters regularly. In case you cannot give amphotericin B, then combination of voriconazole and echinocandins have been accepted in azole resistance patients, where the echinocandin in the form is given of caspofungin 70 mg per kg body weight, 70 milligrams as loading dose on the first day, followed by 50 milligrams loading of dose from subsequent days till 2 weeks after the culture becomes negative. If the body weight of the patient happens to be more than 80 kgs, then you give 70 milligrams both as a loading dose on the first day, followed by 70 milligrams daily. So in conclusion, I would like to say that fungal diseases, particularly the COVID-associated pulmonary aspergillosis, adds insult to injury in critically ill COVID-19 patients. This is associated with high mortality. Therefore, it is very important to make an early diagnosis and to initiate the appropriate antifungal therapy at the earliest. That is very, very important to have a clinical suspicion so that an early diagnosis is made by whatever available parameters are available with us and to start the antifungal therapy aggressively. In the absence of antifungal prophylaxis, screening of these COVID-19 ARDS patients for COVID-associated pulmonary aspergillosis and other fungal diseases is very, very essential. Thank you so much. And I will be continuing my talks in future on various other topics as well, which are related to COVID.